Well, hello, everyone. Welcome to another episode of ResearchWorks podcast. I'm so glad you could join us again for another great conversation. Welcome back again, Marissa. Thanks for being back.
Thank you for having me again. I love doing it anytime.
I love that you keep saying that, so that it will just keep happening, really.
That's okay.
And this is a good conversation. I'm glad we get to do this one together.
I'm excited for this one very much.
Yeah. So today we have the absolute privilege of having someone all the way from the other side of Australia, New Zealand. We like to say that we're all part of the one big country, really. I think we're all as one. But thank you so much for joining us today, Professor Sue Stott. Thank you for joining us.
Thank you very much, Dana.
It's lovely to have you. And today, the reason why we really are so excited to speak to you today is because we really wanted to talk about a particular clinical area that has gained so much research lately, to such a point where I also see on social media there's a lot of these myths. So we're titling this one, Myths and Facts on Hips in Children with Cerebral Palsy.
And Susan, I'm so excited for this conversation. Obviously, I work as a physiotherapist, and we've been collating over the last few months and years, I guess, questions that we would have for orthopaedic surgeons, not only from us as clinicians, but from families.
Yes.
But before we jump into things, let's tell our listeners a bit more about you. So Professor Susan Stott is a professor of paediatric orthopedic surgery at the University of Auckland in New Zealand and paediatric orthopedic surgeon at Starship Children's Hospital in New Zealand. Professor Sue Stott was the second president of the AusACPDM and was the only New Zealand investigator on the NHMRC Centre for Research Excellence, Australasian Cerebral Palsy Clinical Trials Network, hosted at the University of Queensland. She's the clinical lead of the New Zealand CP Register and on the reference group of the newly formed Neurodevelopmental Network under the auspices of the Paediatric Society of New Zealand. She therefore has the ability to translate key research findings into clinical practice through strong alliances with key stakeholders within the health sector. In terms of general citation indices, her work has been cited more than 1,500 times and a H index of 34. She has received the Gillies Medal from the New Zealand Orthopaedic Association for Best Paediatric Orthopaedic Research Paper in 1998 and again in 2008. In 2018, Sue was awarded the AusACPDM Transformative Practice Award winner, and she also received the prestigious Presidential Award from the New Zealand Orthopaedic Association. Sue, incredible.
You can see why we want to speak to you about this topic.
But before we do, I know there is a lot of questions we have for you, Sue, but we always do an icebreaker question, which can be a little left field to what we're talking about. But today it's not too bad, and I guess it depends what comes from this.
Too left field.
But the question is, what's the one piece of advice that you would still hold on to today?
That's a really good question. You'll have a lot of people listening who are doing their PhD or postdocs, and a lot of people who are training clinically and looking forward to their first big job. And I remember when I started as an orthopedic surgeon, one of my senior colleagues said to me, one of the things you must do is not take on too much at once. It's very tempting to do so because you've got lots of space at the moment, but be quite particular about what you take on and where you want to be.
Yes.
And I think actually, that's really good advice, because when you first start a job, you've got nothing much to do, and so you want to do everything. And suddenly you turn around 2 years later and your schedule is just jam-packed with all these things that now you think, why did I start that? And I think also you're just going to find that sweet spot for yourself. Like you need to find a space in your role where you've got enough work to really challenge you, but not so much that you're feeling drowned by it. And it's somewhat different for everyone, and you have to know yourself as to where your happy spot is.
Yeah, that's such great advice.
It's getting the balance, and clearly you've done a lot, which is quite incredible. But like you said, it's pacing yourself, and that's good advice to get early on in your career.
Oh, absolutely it is. And I think I can totally relate to that. I remember a mentor saying that to me one day. I'm applying for all these grants, trying to get all of them off the ground. She's like, be careful, because if they all get off the ground at the same time, it's going to be a little bit hectic. And it's a little bit hectic. But that's such great advice. Look, I'm gonna take a completely different steer for this one. When I read this question, when you read it out, I was like, okay, my great advice that someone told me was, you do actually have a separate pocket in your stomach for dessert.
Oh, now you've really gone left. Now that's opening a whole new ball for me.
We talk about food a lot and about dessert, and I know anatomically there's nothing like that, but I'm convinced that is true and it's possible because I push myself every day to make sure that's really possible. But jokes aside, I would say the best advice that someone actually told me from just a whole life perspective is the skill of restraint. And yes, it does apply to my dessert eating, but the skill of restraint, because there are so many great things that you can do out there, but there's nothing worse than trying to do everything but not doing it well and doing it justice. And the skill of restraint is just as important as doing things, because it's better to do it better than to half-fast it, really.
Absolutely.
Yeah.
Absolutely.
See how I related that to my dessert?
Yeah, very good. I thought you were going to stay on that track. That's okay. Look, mine is a bit of a common one. I know it's very talked about these days about gratitude, but just with when we've gone through difficult things in life, and some people I've really looked up to have really grasped that, and that just trying to see the good in amongst the chaos sometimes and the difficulty and really reflecting on the things, even if it's something so simple and small, but that can really lift our thoughts and change our minds and it allows us to give more to those around us as well. So just focusing on what we do have to be grateful for.
Yeah, gratitude's a good one. That's never underestimate that, hey? That's a good skill to practice each day. So good advice, everyone.
Nice rounded.
I really like that. I think I have a lot to reflect on today. So let's get into it now. And you can sort of see that collectively there is a lot of interest in this area and a lot of wisdom that we can't wait to talk to Sue about. And like I said before, it's a whole lot of misinformation that's out there. And I think misinformation can be really damaging because, are we making the right decision at the right time? So let's get into it, hey?
Yeah, let's start right at the basics. And for our listeners, that whether it's families or new clinicians in the area, but just going back to basics. So why is hip status so important in both children with cerebral palsy and other, but also neurotypical children?
So I think normal hip function is incredibly important. So if we look at neurotypical children, we will start screening for hip problems at birth. And we know that a child who has a dislocated hip will, if not operated on, will have a limp. They'll have a weak hip joint because the muscles around the hip won't function normally. And they'll walk, over time, they'll walk with a short leg as well. And as an adult, they're likely to get some pain in that hip because basically their femoral head is no longer articulating with the socket, it's now articulating with the pelvis.
Wow.
So that's for a neurotypical child.
Yes.
Now, the same things would apply to a child with CP. They're probably harder to see because they already have some alteration in their gait patterns. But a dislocated hip will lead to a short leg and will lead to some reduced motion in the hip and can lead to pain over time. So that's really the two reasons of basically the function of the hip and gait, but also the risk of pain later.
Yes,
and that's the two reasons why it's important.
Yeah, and that's so beautifully put and so understandable. And from that point then, when do we start to be concerned? And I guess specifically now, for children with cerebral palsy, at what point do we go, we need to keep an eye on this?
I think from our perspective, as soon as a child is thought to be at high risk of cerebral palsy or is given the diagnosis of cerebral palsy, that's the time to do the first hip x-ray.
Okay.
And it has to be a hip x-ray. Range of motion at the hip is helpful, but it's not necessarily 100% accurate. So you can have a child who seems to have good range of motion in the hip, but they have problems on their hip x-ray. So hip subluxation and dislocation early on is very silent. It's asymptomatic. It's very silent. So there are no signs of pain. And even the range of motion may not give you that much help. So we always recommend a hip x-ray.
And how early would that be now that there's so many great, early detection, early diagnosis, more early than ever before? Certainly in my career, I've seen it really drop all the way down. At what point, and I know you're involved in that work as well, at what point there then from an early diagnosis perspective, is it as early as that? Or
That's a really great question because we've been used to it. Cerebral palsy being diagnosed at a later age. So if we take an example in New Zealand, we know the median age to be diagnosed is about 19 months. Now, there's a wide range around that.
Yes.
But so that's why we say do the hip x-ray. But if we are pushing down to diagnosing a high risk at 3 to 6 months, then I'm not quite sure of the answer yet. But I think we've still got to be thinking in the first year of getting the first hip X-ray done.
Sure.
It's a very low risk investigation to do.
Sure.
And it's the amount of radiation is very low, and if you miss a hip problem, that's a problem. So you're better off, I think, to do the first X-ray within the first year. If you're getting a diagnosis that early.
Because you can still have a hip X-ray. Like, you don't have to be sedated. Is that how it works for someone as young as that? Right. So it's very low risk.
You don't have to be sedated. No. It's very quick.
And I suppose from there, then, when we're talking about that really early X-ray, the silent part is the part I'm probably really curious about. When you touched on that, just when there's the range of motion might still seem pretty good, and you don't want to miss it. Why? Do we know why there is this sort of silent hip dislocations that are, not dislocations, but subluxations that might be happening in some kids more than others?
I think our thinking has changed a bit on that in recent years.
Okay.
We used to talk about spasticity around the hip, and we used to say it's a spasticity in the hip adductors and the hip flexors. And that's the problem. And what that led to was the thought that, well, maybe if that's so, then maybe it's just lengthen the hip adductors, lengthen this flexor muscle, or else maybe inject them with botulinum toxin A, and that will actually solve the problem. And actually, the reality is it doesn't solve the problem. So it's a much bigger, it requires a bit more thinking about it. And I think now what we're thinking, yes, there's spasticity, but there's also weakness, particularly weakness in the hip abductor muscles, the hip extensor muscles. So you're not getting the normal pull on the bone, and what you're getting is progressive changes in the way the femur grows over time and the way the acetabulum grows over time. So you actually got a problem with femoral growth as well as a problem with weakness of muscles and spasticity of muscles.
That's really interesting.
That combination thing. So actually, if you follow the X-rays over time, you'll see that at the beginning, the first X-ray looks normal, and then over time, you see progressive changes in the hip. And that's all about the growth not occurring normally in the proximal femur, and that's related to muscle pull.
That reminds me of that lovely diagram that I saw, it was probably a good 20 years ago, about the positive and the negative influences, right? So there's the spasticity in tone, but negative is the weakness and hypertonia. So this is where it becomes really important, considering the two components of it.
Yeah, and I think we know that about cerebral palsy in general. We've thought a lot about positive features of spasticity and thought very little about the negative features, the weakness. We know that around the knee, for example, you don't just have spastic hamstrings, you probably have weak quadriceps as well, and you have the two things together.
And I suppose the focus has always been on the positive, because when there's too much, we try to dampen it down a bit. So the emphasis on botulinum toxin and particularly, I suppose, was a big thinking. So do we know at the moment how effective botulinum toxin is for the management of hips? Like, if someone were to say, and I guess this is possibly a myth, erring on fact, I think this is where things are not very clear, is botulinum toxin something that's useful for preventing hip surgery, if I can be as bold as that?
I think there's really no evidence that it does prevent hip dysplasia in children with cerebral palsy. It would be nice if it did. When you think about it, the other factors it's not addressing all the problems. It's only addressing one.
No, that's really important.
Well, my brain is just going with more and more questions, but I'm going to try and stay on track. Now, this is a really big one. And I know when I started in paediatrics, this was a big thing as well, is parents being told if they get their kids up and standing and weight bearing more, that it might prevent surgery. And this is when they were starting to demonstrate, increased migration percentages, and their hips were starting to I guess, displace or sublux out, and parents were told if you get them standing in their standing frame more, it may prevent the surgery. So parents felt this pressure. So I want your thoughts on, does standing or walking, can it prevent surgery, or is the relation to hip surgery more just related to GMFCS?
I think we know the risk of hip problems is definitely related to GMFCS. So about 1 in 3 children with cerebral palsy will have problems with their hip during childhood.
Right.
So in terms of hip subluxation,
yeah.
dislocation, so that's pretty high.
Yeah.
But if your GMS is level 5, the data suggests that maybe up to 90% of children with GMS level 5 will have problems with their hips.
Wow.
Whereas if your GMS is level 1, the risk is very low, probably pretty close to being neurotypical.
Wow.
So it's definitely GMFCS related. It's not so much related to diagnoses such as spastic diplegia or spastic quadriplegia, but GMFCS is very predictive. There's that nice paper that came out of Melbourne quite a few years ago showing a graph, and it's a linear relationship between the GMFCS and the risk of hip subluxation. So that's what we're dealing with. Does standing make a difference? I just don't think there is evidence in the literature to say that. I think there's lots of reasons to be in a standing frame. I think it probably is good for your bone density. It gives you a different vision of the world. It gets you at the same height as your peers. It allows you to use your upper limbs more effectively. So there are lots of reasons for using it, but I don't think preventing hip dislocation is one of them.
And that's an important thing to be able to talk about. I saw something that really broke my heart, and you know, families do communicate so much online through social media platforms to support each other and share stories. And I read one thing where a parent had just seen their orthopedic surgeon. They were devastated because their child needed orthopedic surgery for their hips, but they had spent all this time doing standing, doing all the therapy, and her question was, where did I go wrong? And that was hard to read. And so I suppose it's really important to bring it down to the fact that there is this, like you said, this linear relationship with GMFCS. There is some children are more susceptible for this to be the case. What would your advice be to families who, you know, I'm sure you have these conversations with them all the time when they come to see you and you say, look, the best course of action is surgery. What do you say?
And it's very difficult because we're talking about something which is silent, is asymptomatic. Then we're talking about going through, taking an X-ray and saying we're going to do a hip surgery, and then we're going through a big surgery, and at the end of it, from the parent's point of view, not much has changed.
Sure.
You know, we haven't actually changed much about the function for that child. Maybe it's easier to get the legs, put the legs apart for doing perineal hygiene, changing clothes, but they're going through a lot, and we're saying, oh, look, it's great, the hip X-ray looks so much better now, but actually since the condition was silent and asymptomatic and pain-free to start with, it's hard to go through that. I think a real problem is that actually for normal hip growth, you have to be walking and running and playing and be up and active, like a neurotypical child is. And so I think walking in a supportive walker isn't probably going to be sufficient. And the real question in the research is, how can we do better than that? How can we get closer to what the demands of walking, which is how do we get more activation of muscles? Because I sometimes see parents that they're walking their child, but it's actually the parents are really walking. And the child is leaning on the parents and is not using their muscles that much. And so how do we get past that to something where we can get more activation of muscles?
I mean, I think
I think that's part of the reason. To me, that's part of where the research needs to go, because we need to move past that kind of.
I love this because it's
the parent doing holding the child up, doing most of the stepping for the child. We need to move past that.
And like I said, that's where the research has been heading from a therapy perspective as well, is, you know, making the child be active so they can self-initiate movements and generate strength. And that's something we're so passionate about, is it's that early on-time mobility framework, getting kids up and moving for the many benefits you spoke about. But I guess one of the added benefits, if they're doing it themselves, is that they can be building some of that muscle strength.
That's beautifully said, Marissa. And I think that it comes down to that. We've been that's where the thinking has been, the research has been going lately, and it's so consistent now. The on-time mobility framework, for listeners who might not have heard that episode yet, is really about trying to get children up on their feet when their peers are. So if it's in a supported stepping device when they're 9 months, get them up, get them moving. But it's not about us moving them. It's never been about us moving them. One, from a motor learning perspective, they're not learning. But secondly, now, as you highlight so beautifully, Sue, it's actually because we want them to use their own muscles for them to be as active as possible. And that's probably something that's been not well researched yet, because I think the thought processes have been more active now. We're finally there. We know we want to be, what's the recommendations for physical activity? We haven't been able to really meet them because we haven't really created an environment where children can be more encouraged to be on their feet, active, and supported stepping devices early on, but doing it themselves. You know, it's less about the handling, isn't it?
Absolutely.
That's a really important point, and great area for future research. Yes, that's a very good one.
I love this.
Yeah. Can I just clarify some things? I feel like sometimes with my language and when I'm talking to families, displaced, sublux, dislocated, there's a lot of different words that I've used for hips. What is the preference? Like, how do we describe hips through all its statuses? Because I feel like maybe that's a good thing to go through, that process of, I guess, surveillance. But what are the words around that?
I think probably the best way is if you're describing X-rays to talk about the migration percentage, which is how much the femoral head is migrated out of the socket. And radiologists can measure that for you and report it. There's a defined way to do that, and we say that a 30% migration percentage, they should be referred to an orthopedic surgeon at that point. We're usually not recommending operative intervention at that point, but we are recommending more closely follow-up, and by the time you're kind of 40-45%, surgeons will be thinking about operating. Once you're at 80%, that actually is dislocated. Now you're dislocated.
That's dislocated.
Before that, you're probably subluxated. But I think you're right. There's a lot of terminology in X-ray reports that are really confusing. Just talking about uncoverage, displaced, and it's what you really need is the migration percentage, because now you can quantify it. You've actually got a number on it, which is now you can actually have something you're measuring. That, provided you have a good X-ray, you should be able to reliably measure that each time.
Yeah, brilliant. And I guess that's the point of hip surveillance, is to monitor that hip migration percentage and make sure that they get time intervention. So I guess from there then, what actually is done, we kind of touched on it a little bit, but I thought it'd be worthwhile going through some of the surgeries that you do perform. So talk us through what that starts to look like, because I think there's the muscle releases, and you hear about that. There's the single level and there's multi-level. Help us through that.
Okay. So I think it varies depending upon the age of the child, and we also tailor it a bit depending upon the functional level of the child. So if the child is ambulatory or non-ambulatory. Where the most controversy comes in is in the very young child. And what we know is that children who are GMSS level 5, their hips tend to dislocate earlier. So if you look at not just whether they dislocate or not, but when. So if you're GMS level 5, it can happen very early. So by the age of 18 months, you can have X-rays that look significantly problematic. And whereas a child who's maybe GMS level 3, it may not be until quite a few years later. So that's why surveillance needs to go on throughout childhood. We can't just draw a line and say, oh, if you're fine by the age of 3, you're going to be fine. You have to continue it. So for the child who's GMS level 5, often hip subluxation occurs early, and it's a really quite challenging decision as to what to do at that point, whether we follow for a while and accept we'll be doing a fairly big surgery when they're a bit older, or whether we try to do some sort of soft tissue release. And I think in the past, there were a lot of conversations about doing adductor releases on the basis that adductors with spastic muscle, and they were the cause of the problem, and then some people added psoas as well. Adductor release alone doesn't work particularly well, and its failure rate is probably the biggest in children who need the help the earliest, basically. So I think the research is still coming in on what can we do for the very young child with subluxated hips, who's often quite frail, they're quite small, they're not really suitable for big surgeries, but we know the hips are already becoming a problem. So there's quite a lot of discussion. There's a really interesting paper co-authored by Kerr Graham and Jason Howard in Journal of Clinical Medicine in 2023, which is a very reflective paper. And they talk about the clinical, ethical considerations for hip surgery and management of cerebral palsy hip disease, and that's actually worth reading.
Yes.
And you can download that. That's online.
Yes.
So they talk about, well, should we try and do some sort of form of guided growth? So we're saying that growth is a real problem and the proximal femur is growing into a lot of valgus. Shall we actually try and modulate that growth by putting a screw across the growth plate and therefore changing the growth at the level of the growth plate?
Oh, wow.
And that's actually quite new.
Wow.
We don't know how it will work, whether it will work, but it's actually quite nice thinking, because it's saying, well, actually the growth problem, and the growth problem's getting worse, it's growing to more and more valgus, so let's try and modulate that early on and change the way the femur grows.
Wow, that's a very interesting thought,
so
isn't it? Very novel.
That's coming. I think, so it's being studied now, so we'll get some data probably in the next few years on this.
Amazing. Okay.
So that's a group in which are challenging, but for older children, what we do is more agreed, and it's usually a femoral osteotomy, where we're cutting the top end of the thigh bone and really usually changing the neck shaft angle, so changing out of so much valgus, putting it back to a normal neck shaft angle, putting the femoral head back in the socket and fixing that with a metal plate. We may need to do some muscle release as well. If the adductor has become very contracted, we will release a little bit of the adductors. Sometimes you might want to release the hip flexor as well, and sometimes you might want to do a pelvic osteotomy if the acetabulum is very dysplastic. But we tailor that a bit depending upon the child, their function, and the X-ray.
Sure.
Now that surgery is quite a big surgery to go through. And I think the issue for parents with that surgery is that firstly, the child doesn't look too different afterwards, but also it's not one surgery and that's it. There may well be repeat surgeries in the future. And that's another challenge for us as well as surgeons. How do we move from that model of you have osteotomies at the age of 5, and then by 7 or 8 we need to redo them again.
The birthday. There was a term for that, wasn't there? The birthday.
I used to call it the birthday syndrome. That was more for surgeries around gait. But certainly for hip surgery, we do know that yes, there's a recurrence is a problem. And again, it's because of the altered growth. And so I think we're thinking about how can we prolong the effects of the surgery we do. That's really what it comes down to. How do we prolong it? So we don't have children having repeat surgeries.
So when they have these repeat surgeries, the reason for it is once again the hip migration percentage again increases despite the original surgery to shape them.
Again, the hip then starts to resubluxate again. And I think we think that's all to do with the fact that we haven't actually changed the growth, what's happening with the growth of the proximal femur. All we've done is change the shape of it. But then as it remodels back to where it was. And that's
and once again, weakness remains the thing, isn't it? Like we haven't targeted that.
It's a problem as well.
In terms of doing that surgery, you mentioned that femoral derotation, and we know what you said, their migration percentages are around 40, 45, you start to discuss it. Is there a point when their migration percentage is too high or their hip is too displaced or sublux to have that surgery done?
I think there's probably a small group for who are too frail, who have too many medical comorbidities. And so you're weighing up the risks versus the benefits in that group. And I guess CP you have the physical disability side, but then you have all the complex medical comorbidities that go with it. So there's probably a group that they're just too frail. There's that group. And sorry, I'm just losing my track now. You just remind me again of the question.
It was just, how if migration percentage is around 40, 45 when you're operating, is there a percentage when it's too increased to be able to do the femoral derotation? And you'd have to look at another surgery?
Well, that's an interesting question, because we can always put a hip back into a socket as long as the child's... we can't in an adult because the socket is too dysplastic. But until we've got a really dysplastic socket, we can always put the femoral head back in. So for neurotypical children with a dislocated hip, it could be 100% dislocated, we can put it back. But there is a point at which there's no socket to put it back into.
Right.
And that's really as you get into teenage years, there just may be no socket, because the socket won't form unless the femoral head is in contact with it.
Yeah.
So if there's been a dislocation which has been present for many years, there really is no socket to put it back into.
What happens then? Because I imagine it could be quite painful by that stage.
Yeah, so that's why that's why we do recommend surgery for hip subluxation, cerebral palsy hip disease. We don't think the outcome of not doing anything is particularly good. It's really debated in the literature whether everybody gets pain, but certainly a significant percentage get pain. And I guess I say to parents is that once children get pain from a dislocated hip in CP, it's actually really difficult to get rid of that pain. So you can do a surgery and put the hip back, but the pain takes a long time to go away.
Yeah, sure.
And a lot of help from your pain team is needed.
Yeah.
So it seems that once the hip becomes irritable and painful, it's hard to change that.
Yeah. That makes sense. So it's why we're trying to screen, why we're trying to intervene at the right time, because I guess what you're saying is once the hips are displaced, the surgery becomes a lot more complex. The results may not be the same. Pain is more of an issue. Yeah. So now that kind of brings me to another tact of what conservative efforts can be done to prevent surgery, if any, and how effective are they? I know we've spoken about botulinum toxin injections and a little bit about strength, but what are your thoughts on this?
Swash braces at one time. Anyway, I'll leave it to you.
Yes, there was. There's a study on the swash brace and botulinum toxin A injected into the adductors. It really didn't show results that were convincing. So I think the answer is no, that bracing doesn't make a difference and botulinum toxin A doesn't make a difference in the long run. It's really hard because even sleep systems probably don't make a difference. I think what makes it's all about active movement. So in fact, it kind of makes sense that passively putting the hip in a certain position doesn't make a difference because it's actually about active muscle pull on the femur. So in fact, what you want to be doing is almost the opposite. Rather than positioning in a brace or positioning in a sleep system, you actually want to be getting movement in the joint, but you want active movement. And it's how you as therapists bring on active movement. So I sort of watch, like, buddy walking is still quite popular, but it feels like buddy walking with the parents behind the child and literally pushing their leg forward with their leg is actually not walking.
It's not. No, but, it's not. It's not activating the same muscles.
That's not encouraging. So how do you get to active movement? How do you get from that, which gets the child up and feeling the stepping process? Which is good. How do you get from that to then the initiation of movement?
Look, when you sort of have gone through all the conservative approaches, when you really think about it over the last 20 years, and I don't think I've ever stopped to really think about it, all the research that we have done in the area has all been passive. It's all been about positioning, hasn't it? And I think we can finally say after all these decades, it isn't working. It hasn't worked. It's not what we've expected or wanted it to be. So I think it's another line in the sand to go, okay, let's look at the other end. If we look at the positive and negative, well, let's look at how we can look at the negative features and how we can build strength. And it's really interesting. I've never actually stopped to think about that. All the research that has been done has all been passive and positioning and bracing.
It's true. Standing frames, splinting,
And we've been talking about that for so long that I don't think we've actually stopped as a whole profession together to go, okay, this is definitely what the research is saying right now, and we're really trying to look at different things and it's time to move on.
This makes me excited with now what we're doing with getting kids up earlier, and we're so passionate about them initiating the movement and building the strength. Will that have an impact on their hips? It's something we can
I mean, the hip joint is designed to move, and it's it moves in all dimensions basically. It's a ball and socket joint.
That's right.
So holding it in just one position probably is not going to do that much for helping it grow and develop. When you think about it.
And when you think about how you know this, Sue, but I'm just saying it for my sake now. But when you think about where the muscles are actually attaching glute max, glute med, they are attached to bony prominences that we all know about when we look at our anatomy for a good reason, because it's that pull that creates that and the shaping that creates that. So, the changing directions, the not just moving in a sagittal plane, it's about taking side steps and actively turning. If you're in a walker, you're not walking just in straight lines. You're trying to turn and reposition and steer. because you actually do want contraction around that area. We've got to think about how the hip actually does develop and what's the missing part. And I suppose in children with cerebral palsy, you do have tone, you do have spasticity and dystonia, so you've got those constant messages. We've got to make sure we try to balance it out on the other side. Yeah, that's definitely got me thinking a whole lot about it.
Me too. We were just looking at the hip the other day because we're looking at the pool of different muscles, and because more and more as therapists we're looking at, having that stability for children around the hip regardless of their GMFs, even for GMFCS 1s, 2s and 3s, because we know that stability is important around their hip and pelvis for not only what's going to happen lower down in gait, but also providing support for their, their spine as they get older and preventing pain. So hips, I remember learning about them as uni, and as soon as you learn it's a ball and socket joint, you start thinking, gee, there's a lot of muscles involved here.
Always revise our anatomy and actually look at where the muscles are attaching to, because that is important.
Yeah.
So now that we've sort of spoken a little bit about the surgery, can you talk us through a little bit of what the recovery time often looks like and what you'd expect to see? Is it I think that's always an interesting point, because that's often the hesitation, right, for a lot of families to go into surgery is what's on the other side of it? What am I going to face?
Yeah. So I think for families is a big thing to go through, but I think they can be reassured that most paediatric orthopedic surgeons, it's actually, from our perspective, a fairly routine, what we call routine operation, which is good, actually. It means we do it a lot. We're pretty familiar with it. We've got it all sussed in terms of what's going to happen next. So in terms of the surgery, we often will recommend operating on both sides, even if only one hip looks like a problem.
Okay.
And I know that's a question that comes up over and over again. And the reason for that is that otherwise, if we operate on one side and put the hip back, we've often shortened the leg a bit in doing that. So now we've suddenly created, unequal leg lengths.
Yeah.
And the other thing is if we lengthen muscles a bit on the operator's side, now that muscles aren't balanced anymore.
Right.
So our feeling is it's much better to do both sides unless there's a real reason to only do one. And that might be a child who's very asymmetrically involved. So one side is very involved and one side isn't. Then you may not do both sides.
Okay.
Or a child who's very frail, maybe.
Okay.
You feel it's just too much to do. But usually we'd recommend both, so that then you end up with legs that are the equal length.
Yeah.
That have a similar range of motion at the end.
Okay.
Yes, that's the goal. We're pretty good. It's a pretty standard. We cut the bone, we turn the bone, and we put a metal plate on. And our metal plate fixation is much better than it used to be. So we have much better metal wear, so it's much stronger, it's more rigid, and therefore it's more comfortable for the child afterwards. At Starship, we don't use any plaster casts afterwards. We're happy with our fixation.
Right.
We do use foam abduction wedges. But this is another thing in the research that people are saying, well, actually, if you're really happy with your metal wear fixation, do you need a foam wedge even? I guess what we're thinking about, well, maybe it helps a little bit with the pain relief post-op. If you're not having too much spasm, maybe it helps control spasm, but maybe you don't need it.
Yeah.
But we're certainly moving towards, when I train, we put everybody in plaster casts of this operation. And the problem with that, the big hip spikers, is kids were, after a while, were comfortable in them. They were, got used to being in one position. But when they came off, sometimes you have pressure sores under the cast, but you're certainly more at risk of things like fracture because their bones have become so osteopenic.
Yes.
Our goal always is to try and get early mobilization. So usually I'm wanting children to be up in a reclining wheelchair by about 48 hours out of surgery. I want them to be out of bed into a reclining wheelchair.
Yeah, right.
And then to be back, my goal is always to try and be back in their regular chair by about 3 to 4 weeks out.
Wow.
And so really advance forward the rehab, because if you can trust the metal wear and say it's going to hold the bone really well, then we can start moving the leg really early. We can start moving the hips and knees. And I think that that's uncomfortable at first, but usually by about 4 or 5 days out, kids are a lot more comfortable. So usually I tend to operate on a Wednesday, so by Monday they're really ready to go home. In fact, they probably could have gone home for the weekend.
Wow. Okay.
Yeah, so I think it's different in different centres though.
Yeah, sure.
How they do things, but that's how I
That's
worked in.
really
I think it kind of
interesting.
matches what we do in adult orthopedics now. We talk
Okay.
about early recovery after surgery, ERAS, and they talk about patients with having hip replacements standing up the night of hip replacement, and they talk about getting children with scoliosis surgery home at 2 or 3 days.
Incredible.
Wow.
And I think in a way, parents do feedback that they're happy once they get home because the child is in their regular environment. They sleep better. They will come. Everything works better than in a busy hospital environment. It's not easy to sleep. It's noisy.
Yeah.
Everything's
beeping.
unfamiliar.
Yeah.
So I think we need to constantly be thinking about how long do we need to keep this child in hospital?
Sure.
Why are we keeping them in hospital?
And it's interesting
and really push it forward as much as we can.
When you're saying about the metalwork, I probably didn't quite realize how that's obviously another piece of technology that's improved over time. And so it really has been quite dependent on that in terms of confidence and weight bearing. I didn't quite realize that was the case.
Yeah, I think because we used to have metalwear that wasn't so good, and so therefore you had reasonable fixation, but it wasn't perfect, so you would supplement with the cast.
I see.
And now we have fixation, which is much better. Same with spinal surgery. But all of this has come really from work in adults, actually.
Right.
Do you work with adults with osteopenic bone? So they've worked out all the constructs there, and then you could just apply the same thing to children with osteopenic bone.
That's incredible. Is there any risk of fractures within, like when, that's a common question with metalwork and over time as they're moving, as they're back on their feet, is there a chance of causing little microfractures from the metalwork, or when the metalwork is being removed, does that cause any complications as well?
I guess when you have metalwear on a bone, there is a small risk of fracture just beside the metalwear, but particularly if you had a trip or a fall or the leg was suddenly caught and twisted.
Okay.
The thing is the metalwear is very strong.
Yes.
So the interface between where the metalwear is and where the metalwear isn't is the weakest point.
Okay.
And so you can get fractures just by metal plates.
Right.
And that happens with any kind of fixation, basically, fracture fixation in adults, anyone. But we don't see it that often, actually.
Okay.
I think most of our parents take really good care of our kids with CP. That's why we don't, it's not very common to see.
Okay.
It's more common actually in teenagers and adults who go back on the sporting field and fall and then
Okay, so it takes that much. Yeah.
But after we take the plate out, I guess I just warn parents that there are holes in the bone where the screws have been, and they take about 6 weeks to fill in, and they just need to take a bit of care with the leg. But that doesn't mean they can't lift the child, put the child into the wheelchair, lift back the leg, doesn't mean that. And they usually try and get them to a standing frame in about 2 to 3 weeks out, as soon as they're comfortable.
And
the wounds are healed.
So there's no real restrictions on weight bearing. It's more about just gradual returning to their activity. Is that right? In a safe way, I guess.
It's about gradual return, and it's about being guided by how the child is.
Of course.
Okay.
And you're just tailoring it to how the child's responding. But if they're responding really well, you just advance forward.
Sure.
Okay. Look, I've loved this conversation, and I probably could chat to you for another few hours, but I just want to bring it all back together. You've touched on it. What are we still to know, and like where to for the world of hips and cerebral palsy? And I know you mentioned about, new surgeries that might be coming up around growth plates, but I'm excited to know more about that, or about other things that in your world of hips and children with cerebral palsy, where are we headed, and what are we looking into?
Yeah, I think we're headed into a really exciting time, because I think I've always thought that with hip surgery, we're not really fixing, we're operating on a secondary problem. We're not actually addressing the primary problem, which is cerebral palsy. And so I think we're heading to a very exciting time where we detect earlier, pick up high risk of cerebral palsy earlier, intervene earlier, and that really they talk about the important 1,000 days. So that applies to children with CP just as much as anyone else. The first 1,000 days, how important that is. If we can get some interventions that work really well in terms of taking advantage of neuroplasticity, then maybe we're going to have a group of children who they still have CP, but they won't have such severe CP. And therefore, they don't have such severe CP, they're not so much risk of hip problems. I feel like that's really where the big picture is going to be. And I think
that's exciting.
The whole focus around active therapy. I mean, because when I train, there's a huge emphasis on passive range of motion, and parents having to do stretching the ankles 7 hours a day. And in fact, if you want a child to walk, actually walking is what they have to do. I think they show that in stroke rehab too, that if you want people to walk after a stroke, you have to get them up somehow, get them up and start them taking steps and weight bearing and walking. And you have to figure out how to do that. But actually stretching, lying on a bed and stretching the calf muscle is not going to be able to help someone walk.
No, that's right. Yeah.
And I think we've got to move away from all that passive stretching and into active rehab. And actually really thinking about how we do active rehab for children who GMS level 4s and 5s. How do we do that? But I think we've got to think about it.
Well, that's a big area.
Because that's really about how do we get that muscle, those muscles working, pulling effectively on the bone. So how do you get the hip abductor actually working? Well, it's got to be through weight bearing, because that's what's going to make it contract. If they're taking weight through that leg, and the hip abductor has to contract to stabilize the leg, that's how you're going to do it.
That's right.
You're not going to do it by lying on the bed with the hips abducted.
No, that's right.
Yeah.
Look, I think you've just beautifully contextualized all the conversations we've been having with so many researchers now in terms of, and clinicians going, well, we need to be more active. It's active, self-initiated. The child needs to do the most, and we can apply that to GMFS 3, 4s and 5s as well. And I think it just reinforces why evidence-based practice is so important, because it's not just about the skills they learn, it's about their quality of life. And when you're thinking about hips, it's a big thing if it doesn't go well. So a great reminder for all of us. Great. Hey.
Thanks, Sue.
That was amazing.
Wonderful.
Look, we're not done yet, though, because now I'm sure, well, we'll see how Ed goes in this. We didn't really give him much warning. We're talking about hips today, and we've never really talked about hips. So let's give this one a go, hey? Let's head into the next segment called Tell It to Ed. Ed, as you know, is our producer. He doesn't have a background in child health or hips, but he has been listening on this conversation, and I'm sure he'll have quite a few questions along this line. But before he gets a chance for a question, Sue, I'll get you just to summarise the area of hips and cerebral palsy in about 60 seconds. And Ed will have time for one question. Take it away, Sue.
Okay. So what I say to Ed is that hip surveillance is incredibly important in cerebral palsy. 1/3 of all children with cerebral palsy will have problems with their hips at some time as they grow up into adulthood. And the best way to do that is by regular x-rays following the AusACPDM guidelines. And that as orthopedic surgeons, we want to see children who have hip problems.
Great. Good summary. All right, to Ed, over to you. Are you ready?
Kind of. I will say that, and I say this about just about every episode, it's very enlightening. It's things that I don't know anything about, so I'm learning at the same time as perhaps some of our listeners. And I think it's been so comprehensive that I actually don't have a direct question on this, but I do have a question about something from right at the very start of the podcast. Now, usually the guests do tend to become aware of how great their CV is once it's been read out by one of our co-hosts. So, and given the international audience that we have as well, I just wanted to go all the way back to the introduction for Professor Stott, and where it says that in 2018, she was the AusACPDM Transformative Practice Award winner. And I'm curious what it takes to win one of those awards. Because obviously that seems very prestigious, and transformative is a very strong word. And for, well, I guess my interest and all of our international audience, I'd love to have a guest speak about themselves.
That's a good question, Sue. Please do share. It's good.
So I guess for that award, you're nominated by your peers, and the things that they nominated me for, I had, when I came back to New Zealand, orthopedic surgeons looked after children with cerebral palsy. We had no paediatric rehabilitation specialists, and we were doing botulinum toxin injections, but we weren't doing it that well because we're surgeons. We like to be in the operating room, but we weren't doing a very good job of surveillance and monitoring and orthotics. And so I persuaded the then clinical director that what we needed to do was get 2 paediatric rehabilitation specialists to start up the specialty of paediatric rehabilitation in New Zealand. And that was Iwai Lim and Catherine Edward. And we, what we did was had to unbundle some of the work out of orthopedics and actually give them that piece of work, which meant we gave the revenue as well. And they got it going. And now they've been joined by Jim Chong. And we also have other people around the country showing a good, strong interest in paediatric rehabilitation. So that was one thing.
So
I also,
there's more.
but that was kind of a big thing.
There's more.
That was a big thing to get going.
That's so great.
Basically to just change practice. We also changed, I think, from using hip spikers to no hip spikers for hip surgery. That was another thing I got going. I started the New Zealand Cerebral Palsy Register, and we had a cerebral palsy clinical network for a number of years that I got going, which we've now morphed into a bigger neurodevelopmental network.
Oh my goodness, that's brilliant. That is truly transformative, I'd have to say.
Outstanding.
Yeah.
Yeah, it's great. Very proud of that, because it's to go from having nobody to somebody was so major, and it's made it's made such a major difference to us, because now when I first arrived back, there were a lot of children who needed surgery that not much had, they've been seen in clinic, but not much had been delivered.
Right.
And suddenly we changed to a group of children who were being seen regularly, monitored, had orthotics. And so we no longer get children with really bad contractures now. We just don't, because that's already dealt with before it becomes a real problem.
Yeah.
So I think it's just made such a difference to the kids. Yeah.
Oh, it's very inspiring. That's a really great question, Ed.
Thanks.
Wasn't where I thought you were going to head, but that was a really good one. And I'm glad he asked it, Sue, because just listing the award really wasn't quite enough. But to see what the impact a person can have when they're passionate about an area and really care about an area, it really impacts lives. So very inspiring. Look, to all of our listeners, we will, of course, link the bio for Professor Susan Stott on our website. So do head there, ResearchWorks.net. I'll also put a copy of maybe that link that you were talking about, but the paper from Kerr Graham as well in 2023.
I think it's a really good paper.
Yeah.
It's very reflective, because it's written by Kerr Graham, who obviously has extraordinary amount of experience, extraordinary contribution to the orthopedic research and the orthopedic world, thinking about cerebral palsy. But it's very reflective around where to next, and talking about the ethics of offering operations to children who don't have any symptoms, what's the risks versus the benefits. It's a very good paper.
It's great to stop and think about.
It's very accessible too.
Yeah, sure.
It's not a research paper, it's a reflective paper.
Well, I'll definitely put that link there. That's a great idea. I think that's a great thing. So we'll pop that on our website, researchworks.net, so you can all find it. And remember, there's a copy. You can put a CPD form there as well if you want to keep this as a record of your PD requirements. So thank you for joining us, everyone. And thank you so much, Sue, for your time and your expertise. We learnt so much in that hour.
Thank you very much, Dana and Marissa.
Lovely to have you. We'll talk to you all again next time. Bye.
Bye.
Bye-bye.